picture depicting the Ramsay scale for assessment of level of sedation and the visual analog scale for assessment of the pain. The following statistical tests were applied, the chi-square test and the Fisher's exact test, and a p-value of less than 0.05 was considered as significant. The results which were obtained were there was no statistically significant difference between the two groups with respect to the age and the weight of the patients. There was a statistically significant difference in the heart rate and the mean arterial pressure between the two groups, with decrease in heart rate and mean arterial pressure more in group D than in group M. There was no significant difference between the two groups in terms of duration of the ICU stay, although the group D patients showed early extubation after stopping the sedation. There is significant difference in the additional requirement of analgesia between the two groups, with group D requiring less analgesia compared to group M. Concluding, dexmedetomidine produces better hemodynamic stability compared to midazolam in post-operative patients. Dexmedetomidine sedation reduces the need of analgesics in post-operative patients, and there is no significant difference in duration of ICU stay between the patients sedated with midazolam and dexmedetomidine.
Good presentation, Dr. Shweta. Few things. Is there any specific condition, according to you, Dexmed was better?
Ma'am, we started Dexmed and midazolam randomly in the post-operative patients who were ventilated in the ICU. So, nothing as such. The patients who were not hemodynamically stable, we did not start dexmedetomidine.
Okay. What I want to ask you, is there any specific condition where you would prefer Dexmed, or any specific condition where you, other than this hemodynamic midazolam? Suppose in neuro ICU, which would you prefer?
Neuro ICU, dexmedetomidine is better because it has a neuroprotective effect as well. It reduces the cerebral metabolism, and it has a the studies have proved that it has a neuroprotective effect as well. So in the patients undergoing neurosurgery.
Okay. Yours is a private center?
It is a private and a government center.
And a government center. Again, I'll come to the financial aspect.
Yeah,
that's very important, yes. Actually. We in India, because 90% of the finances are to be taken care by the relatives and patients. So we should be very much concerned about the finances of the patient, because otherwise what happens, patient does not take the full treatment, and in between the treatment, when he starts showing the signs of improvement, they go lama because of financial constraints. So my personal view is, if there is no contraindication directly going for Dexmed, we should initially go for midazolam, and if the patient has the affordability, then obviously we can go for Dexmed. What's your opinion?
Yeah, I feel the same, because we have to take a consent from the patients before, we have to explain priorly the financial aspect as well.
Yeah.
That has a very significant role, of course.
Yeah.
So depending on that, we would start with the treatment.
And I'm not sure about the availability of Dexmed in small cities.
At our setup, it is available.
It is available.
Yeah, it is available.
Okay. Thank you very much. Any other question, please? Thank you.
Next, we would like to welcome Dr. Pankaj Kumar to present his views on high versus low plateau pressure. In arts, low plateau pressure is associated with better outcome and observation.
At the outset, I would like to thank the organizing committee to give me opportunity to be in front of you. high versus low plateau pressure is a burning topic for management of ARDS. Acute respiratory distress syndrome is a sudden and progressive form of acute respiratory failure. In ARDS, inflammatory cells and potential material accumulate in alveolar space, leading to decrease in diffusion capacity. It is also called stiff lung, shock lung, or baby lung. You can see the homogeneous puffy shadow in non-cardiogenic edema, that is ARDS. Common cause are direct lung injury, aspiration of gastric content and other substances, pneumonia, viral or bacteria. Less common cause are pulmonary embolism, oxygen toxicity, chest trauma, drowning, and in indirect causes, sepsis is most common, severe trauma, and less common cause are acute pancreatitis, DIC, and etc. And in management of ARDS, there is no specific therapy for ARDS itself. Only we have to give supportive therapy. We have to buy the time so that the underlying cause may be cured. IV fluid management, maintenance of homeostasis, and mechanical ventilation to manage the hypoxia is all what we can do. And aim of a study is to assess the efficacy of low plateau pressure with high PEEP, that is low driving pressure, and high plateau pressure with low PEEP, that is high driving pressure. Inclusion criteria was acute onset, ARDS that is supported by lung X-ray, bilateral involvement, hypoxemia despite of high FiO2, cardiac cause excluded, and normal central venous pressure. Design of study was randomized, prospective, setting was intensive care unit of our hospital. Total 60% of ARDS were included in study, out of which in peer group there were 27, in PH group 29%, 4% were excluded from the study. Ventilator study was target plateau pressure in group PL was less than or up to 25 centimeter of water. In PH, it was 26 to 30 centimeter of water. PEEP in PL group was kept in between 8 to 16 centimeter of water. In PH group, up to 12 centimeter of water. FiO2 and tidal volume were kept within same range in both groups. Patients who were out of range during the study period were excluded from the study. Now coming to observation in demographic profile, age distribution in PL group was 42.26 plus minus 10 years, while in PH group 41.78 plus minus 9 years, it was comparable. Sex ratio male is to female was 1.25:1 in PL and 1.23:1 in PH. It was also comparable. Predicted body weight was 55.56 and 56.12 in both groups, and they are comparable. And patient excluded in the study in PL group was 3, in PH group was 1. Common cause were pneumonia, aspiration, sepsis, malaria, post-traumatic, poisoning, and non-infectious. Sepsis was most common cause in both groups, followed by pneumonia. Ventilator parameter, mean plateau pressure observed in PL group was 22.23 plus minus 0.9 centimeter of water, and in PH was 27.73 plus minus 1.02 centimeter of water. Mean PEEP in PL group was 12.58 and in PH group was 8.99. Mean FiO2 was in PL group was 0.65 and in PH was 0.66. Mean tidal volume in PL group was 5.42 and in PH was 6.81. Coming to hemodynamic variables, pulse rate in both groups were comparable throughout the study period. Systolic blood pressure was also comparable in both groups throughout the study period. Diastolic blood pressure were also comparable, and oxygen saturation in both groups were also comparable, although in a start both groups had low oxygen pressure before putting patient on ventilator. Now coming to discussion, there are a lot of studies regarding driving pressure, so that so-called low PEEP, low plateau and high PEEP, what were our target. And it was one of the first study which concluded that we found that low driving pressure was the ventilation variable that the best satisfy the risk. Disease in low driving pressure owing to change in ventilator setting were strongly associated with increased survival. There are also a lot of other studies in these relations, some were supporting and some were not supporting. So, coming to our conclusion, this is the complete observation of our study. Day on ventilator were comparable, 6.96 in PH group, 7.28 in peer group, a bit longer. ICU stay was also similar, 9.21 and 9.83 days. FiO2 were comparable, while mean tidal volume was lower in PL group, mean PEEP were higher in PL group, and mean plateau pressure were also lower in PL group. That is, the driving pressure in PH group was almost more than 17, and in PL group was about 10. Out of a study in PH group was 1 and PL group was 9. Mortality was higher in PH group. It was 37% in PH and 33% in PL group. So, to conclude, it was concluded that in ARDS we may get better result if we limit the plateau pressure to 25 centimeter of water, tidal volume at the rate of 6 ml per kg, and PEEP up to 60 centimeter of water is good. That is low driving pressure. Thank you.
Thank you, Dr. Pankaj. You said pH group is better in your conclusion.
No, low plateau pressure with high PEEP is better.
Low plateau pressure with high PEEP.
Low driving pressure.
Can you explain why high PEEP is less dangerous and high plateau pressure?
In ARDS, there is a BV lung, maximum lungs is floated with the fluid, and we have to try to recruit as much as heli lung is there, and so we are also doing prone position ventilation to recruit as much as possible as can. And in high PEEP, what happens that collapsed lung alveoli opens, and basically lung injury are more common if alveoli are collapsing and opening, collapsing and opening. If we give
this is the reason actually.
Yes,
if you keep them constantly open,
yes,
that gives better result.
That is the main reason.
Yeah, very good presentation. One more thing I wanted to ask. All the patients were treated in supine position, no prone position?
No.
Practically, are you people giving prone trial to the patients?
Not commonly, madam.
Not commonly.
Because if we are giving prone ventilation, but for that we have to be on the toe.
Yeah.
Because there are a lot of chances of complications.
Yours is a government hospital?
Extubation means?
Yours is a government hospital?
No. It is a public undertaking, government undertaking hospital. And we try to keep the expenditures as low as possible in our patient. You have said that there is no any extra expenditures marker in my study.
Thank you very much.
Thank
you so much. Sure.
Sir, I just want to know from you two questions, sir. Firstly, was ethical committee clearance taken for this? Because you have now randomly divided patients with possible implications on mortality because of your change of treatment. Because the best practices, clinical guidelines for ARD showing a slight little bit of upward change on that. The second question, I mean, did you take that, sir?
First question, you have told rightly, ARDS net says that plateau pressure should be
to maintain the same?
Not much, because the range is not very large. Not much change was in pressure
In conclusion, what I understood from your study is it is correlating with what we know already as the best practice guidelines of ARDS, that is increase the PEEPs and have as much as limitation of the airway plateau pressures for better outcomes.
You can say.
Okay, thank you.
Thank you. Our next presenter is Dr. Sania Parveen. She is presenting a study to assess the association of pooled subglottic secretions with cuff pressure in mechanically ventilated patients in ICU.
Good morning, everyone. Myself, Dr. Sania Parveen. I am a resident in JNMCH, AMU. The topic of my study is to assess the association of pooled subglottic secretion with cuff pressure in mechanically ventilated patient in ICU. So coming on to the introduction part, endotracheal tube cuff pressure measurement is an essential part of airway management in intubated and mechanically ventilated patient. Silent aspiration of pharyngeal secretions through leaky cuff has been associated with ventilator-associated pneumonia, that is VAP. Therefore, apart from maintaining correct cuff pressure, it is important to perform cuff pressure measurement at 6 to 12 hourly interval. This study was done to assess the association of pooled subglottic secretions with cuff pressure in mechanically ventilated patients. Now coming on to the material and methods. It was a prospective observational study taking individual patient, and it was conducted in June 2017 to May 2018. Inclusion criteria, all patients having age between 20 to 60 years, endotracheal tube with suction port of 6.5 mm to 8 mm internal diameter, and patients receiving mechanical ventilation for greater than 12 hours were taken in this study. In exclusion criteria, we excluded the patient who have tracheal disease or abnormalities, or there is history of any acid ingestion post CPR patients. Now sample size was 250, and the study tools were suction above cuff endotracheal tube, cuff pressure manometer, and a 10 ml syringe were used to suction the secretions. This is the suction tube, Collis sachet, and this is the manometer which we use for measuring the pressure. Now coming on to the data collection procedure, all the patient received sedation, that is midazolam infusion at rate of 0.02 to 0.2 mg per kg per hour, and analgesic, that is fentanyl, which is given 20 to 50 mics per hour infusion. The patient were kept in volume control or pressure control mode, that is the assisted PCV or assisted CMV mode. The cuff pressure and the leak in the cuff was assessed clinically. Baseline cuff pressure was considered at a pressure when no leak was observed after insufflation. Subsequently, cuff pressure measurement was done every 3 hourly. Simultaneously, suction of the pooled secretion, if any, above the cuff was done. If the ventilator showed a leak of more than 5%, then a cuff pressure was noted, and the volume of air required to occlude the leak was also noted. If leak was observed in the graphics of the ventilator before the scheduled 3 hourly reading, then the cuff pressure was measured and the air was insufflated till there was no leak. All the parameters were measured every 3 hourly for a period of 12 hours. Now coming on to the observation. This is the first table showing demographic profile of the patients. The mean age were 38.82, and there were 128 male and 122 females, and mean weight was 54.42. Now this is the diagnosis of study population, and majority belong to the medicine patients. Now table showing number of patients with baseline cuff pressure and subglottic secretion at different time interval. So number of patients with a baseline cuff pressure at 3 hours were 160 with a mean cuff pressure of 24.9, and number of a patient with a subglottic secretion with baseline cuff pressure were 91 out of 160. At 6 hours, 60 patients were with baseline cuff pressure and with a mean cuff pressure of 24.81. And number of patients with subglottic secretion were 52 out of 60. At 9 hours, 115 patients were with baseline cuff pressure and mean cuff pressure of 24.73 centimeter of water, and out of which 67 were having subglottic secretion. At 12 hours, 60 were having baseline cuff pressure and mean cuff pressure was 24.16 centimeter of water, with a subglottic secretion in 45 patients out of 60. Now second table is showing number of patients with reduced cuff pressure and subglottic secretion at different time interval. So at 3 hours, 90 patients were having reduced cuff pressure, having mean cuff pressure 21.33 centimeter of water, and with subglottic secretion 32 out of 90 patients were having subglottic secretion in reduced cuff pressure. At 6 hours, 190 patients were with reduced cuff pressure and mean cuff pressure was 20.43, and 37 out of 190 were having subglottic secretion. At 9 hours, 135 were having reduced cuff pressure and mean cuff pressure was 20.34, and 30 out of 135 were having subglottic secretions. At 12 hours, 190 were having reduced cuff pressure and 20.13 mean cuff pressure was present, and 36.190 were having subglottic secretion with reduced cuff pressure. Now coming on to the next table, which is showing comparison between number of patients with subglottic secretion with baseline cuff pressure and reduced cuff pressure. So at 3 hours, number of patients with subglottic secretion with baseline cuff pressure was 91, and number of out of 160, and number of patients with subglottic secretion with reduced cuff pressure is 32 out of 90, which is not significant. Then number of patients with subglottic secretion with baseline cuff pressure at 6 hours was 52 out of 60, and number of patients with subglottic secretion with reduced cuff pressure was 37 out of 190, which is statistically significant. Then at 9 hours, 67 patients was having subglottic secretion with baseline cuff pressure, and 30 out of 130 with reduced cuff pressure. This was also statistically significant, and at 12 hours, 45 out of 60 were having subglottic secretion with baseline cuff pressure, and number of patients with subglottic secretion with reduced cuff pressure was 36 out of 190, which was also statistically significant. Now coming on to the last table, showing comparison between volume of subglottic secretion in patient with baseline and reduced cuff pressure. So volume of subglottic secretion in baseline cuff pressure was mean secretion was 2.35 ml at 3 hours, and in reduced cuff pressure it was 1.5, which was statistically significant. In 6 hours it was not significant, but at 9 hours it was again significant. That is, volume of subglottic secretion in patient with baseline cuff pressure was 1.5 ml, and volume of subglottic secretion in patient with reduced cuff pressure was 1.18. That was also statistically significant. At 12 hours it was not statistically significant. So now coming on to the discussion part, there was significant reduction in volume of subglottic secretion accumulated above the cuff in patient with reduced cuff pressure from that found in patient in whom baseline cuff pressure was maintained. So with reduction in endotracheal tube cuff pressure, the volume of pooled subglottic secretion reduces. So it would be advisable to monitor the cuff pressure if possible continuously or at least at frequent interval of time. This would definitely prevent microaspiration of secretion accumulated over cuff. The future scope of the study is to determine how frequently cuff pressure should be monitored or subglottic secretion be suctioned. Further larger studies needed to study the amount of subglottic secretion correlated with change in endotracheal tube cuff pressure. Now coming on to the conclusion, endotracheal cuff pressure reduces over time and it is positively correlated to volume of pooled subglottic secretion above the cuff, that is with reduction in endotracheal tube cuff pressure, with the volume of the pooled subglottic secretion it reduces. Thank you.
Nice presentation. First of all, I would like to know the cost of this instrument.
Yes, ma'am.
How the measurement, for the measurement, how much does it cost?
Ma'am, actually, ma'am, the normal tube cost around 120, and this tube.
I'm not asking the tube, the instrument.
Ma'am, we have not used any instrument. We have just changed the tube. Normally, we use the normal.
You are measuring the pressure, no?
Yes, ma'am. Ma'am, it's actually available in our ICU. We have not
okay, you have not purchased.
Added for this study. And ma'am, the cost of this tube was around 30 rupees more than the usual tube.
Yeah, that I know. That I know. It's not very costly, so we can easily afford to have this in every patient. Yes, yes. Your exclusion criteria was post CPR. Why?
Yes, inclusion criteria, ma'am. Exclusion. Yes, ma'am. In exclusion criteria, we excluded the post-CPR patient, because in post-CPR patient, there is more risk of already gastric aspiration may be present.
No, suppose a patient...
Yes, patients will already be aspirated. So it will not be easy to assess, not be beneficial to assess the ventilator-associated pneumonia in these patients.
So the criteria should be aspirated patient, not the CPR
non-aspirated patient, so that we can assess the incidence of VAP in these patients with the volume of the subglottic secretions which we are aspirating through syringe.
And why 3 hours interval? Why not 2 or 6 or 4?
Ma'am, by the references, we have included 3 hours.
Okay, anybody else? Any other question? Thank you.
Our next speaker is Dr. Lakshmi. She is presenting a comparison of short sedation between dexmedetomidine.
In ICU, hello, 1 minute. In ICU, we are fighting with ventilator-associated pneumonia, and it is supposed that, it is not proven, but it is supposed that it is due to micro-aspiration. And you are decreasing the cuff pressure, and simultaneously you are telling that there is secretion is less. Where is secretion going?
That's what it is about. In this study, we have shown that secretion is reduced because it is aspirated. Because the cuff pressure was in which there is reduced cuff pressure, there is reduced secretion. So it is reduced because it is aspirated. So it is advisable to maintain the cuff pressure at a permissible limit, so that the secretion can be maintained above the cuff, so that we can easily aspirate by suctioning.
If pressure is higher, then where secretion will go?
We don't have to keep the pressure at high level, because it will also cause a various problems like tracheal stenosis, yes, and necrosis. But we have to keep the pressure at a permissible limit, so that the pressure is not very high and not very low. So that if it is high, it will cause complication, but if it is very low, then the secretions will be aspirated, so which will lead to VAP.
Thank you.
So that's why monitoring is important at 3 hourly, so that we can maintain the cuff pressure.
Thank you.
Thank you. Our next speaker is Dr. Lakshmi. She is presenting a comparison of short sedation between dexmedetomidine and propofol for post-operative mechanically ventilated patients in ICU, a prospective randomized study.
Good morning, one and all. I am Lakshmi from Andhra Pradesh, and today my topic is about the comparison of short sedation between the dexmedetomidine and propofol for post-operative mechanically ventilated patients in ICU, a prospective randomized study. Coming to introduction, critically ill patients requiring mechanical ventilation frequently need sedatives and analgesics to facilitate their care. The concepts of analgesia and sedation in intensive care medicine have changed considerably over the last decade. Deep sedation is no longer the standard practice, as it prolongs the weaning from mechanical ventilation and length of the ICU stay. Inadequate sedation can result in anxiety, agitation, recall of stressful experiences in the post-ICU phase. Propofol has a number of properties which makes it potentially superior choice for ICU intubated patients, such as a rapid onset and offset even after prolonged administration. Dexmedetomidine is a sedative with a high affinity for alpha-2 adrenoreceptor. It doesn't interfere with respiratory rate and arterial oxygenation and carbon dioxide pressure. The aim of this study was to investigate and evaluate the efficacy and safety of dexmedetomidine in comparison to the propofol in the management of sedation for post-operative intensive care unit patients as a sedative agent. Materials and methods. This is a prospective randomized comparative study. It was conducted on patients admitted to the ICU after surgery in the period between the July to October 2018 after obtaining Hospital Ethics Committee approval and patient informed consent. 60 mechanically ventilated patients aged between the 20 to 50 years were included in the study. They were randomly allocated into 2 groups of each 30. Group D received dexmedetomidine loading dose of 1 mg per kg over 10 minutes, followed by the maintenance of 0.2 to 0.7 mic per kg per hour. Group B pupil received propofol loading dose of Group B people received propofol loading dose of 5 mic per kg per minute. The infusion rate was increased by increments of 5 to 10 mic per kg per minute until the desired level of sedation was achieved. Inclusion criteria includes age 20 to 50 years, elective general surgical procedures, and ASA 1 and 2, and visual analog score more than or equal to 4, or AMSA sedation score of less than or equal to 2. Exclusion criteria includes allergic to the study drug, pregnancy, severe respiratory and cardiovascular or neurological disorders, prolonged sedation requirement. Parameters compared are pulse rate, respiratory rate, blood pressure, mean arterial pressure, SpO2, Ramsay sedation scale, and visual analog scale, recovery time from sedation, and analgesic requirement. Sample size is determined by this formula. Coming to the results, demography includes parameters, number of patients, age and weight and gender. All these parameters are comparable and insignificant. Cardiorespiratory variables, a pulse rate, respiratory rate, systemic blood pressure, systolic blood pressure, diastolic blood pressure, and mean arterial pressure. All these parameters are comparable both the groups and insignificant. Ramsay sedation score for both the groups are comparable and insignificant. Visual analog score for both the groups are comparable and significant. Dexmedetomidine group requires more analgesic requirement than propofol group. Coming to the discussion, this observational study is investigating the effect of dexmedetomidine versus propofol in patients requiring sedation in intensive care unit. Dexmedetomidine is an effective as propofol for producing and maintaining adequate short-term sedation of critically ill and mechanically ventilated patients. Cardiovascular stability and respiratory function were maintained with the dexmedetomidine and propofol. The benefits of dexmedetomidine over currently available sedative agents include its shorter half-life, lack of respiratory depression, and its ability to decrease the need for opioid analgesics. The administration of a bolus of 1 mic per kg dexmedetomidine initially results in a transient increase of the blood pressure and a reflex decrease in the heart rate, especially in younger patients due to a peripheral alpha 2 adrenal receptor stimulation of vascular smooth muscle. The effect can be attenuated by a slow infusion over 10 or more minutes. The initial response lasts for 5 to 10 minutes and is followed by a decrease in blood pressure of approximately 10 to 20% below the baseline values and a standardization of the heart rate. Both of these effects are caused by the inhibition of the central sympathetic outflow or stimulation of the presynaptic alpha 2 adrenal receptor, leading to a decrease in norepinephrine release. Conclusion. In the present study, dexmedetomidine is a safer and effective agent for sedation of mechanically ventilated patients admitted to the ICU after general surgeries. Depth of sedation is similar to that given by propofol and expiration time is equally rapid and similar. The cardiorespiratory variables of the patients sedated with the dexmedetomidine are similar to that of patients sedated with equipotent doses of the propofol. These properties combined with the analgesic qualities